Hello everyone, I'm Dr. Abraham. So someone had requested that we make a presentation about alopecia and hair loss. So this is the first one that we've made today. In this particular video, we shall look at the common baldness, or what you call male pattern or female pattern, androgenic alopecia. So in this case, this is quite a very common condition that almost occurs in any race, and it can affect any individual depending on the genetic profile that you have. And as you age, the manifestation becomes more clear. As you can see in these pictures that I've shared on my screen, you'll find that we've had prominent individuals. For those who are supporting football, at least you know Mo Salah, currently playing for Liverpool. He had this chronic problem that he was progressively losing hair, which started around the temporal region around here. And because of this, he had to go and get a hair transplant. And then currently, this is how he looks like. Then we have this other legend in Manu, Wayne Mark Rooney, and he also had the same problem. And then he also had a hair transplant, and that's how he looks like currently. And you'll find that so many people have had the same. And when you look at this picture, like in this picture here, someone had this progressive alopecia androgenic pattern, and then after hair transplant, this is how the hair was looking like. So it is a common problem, and today we shall look at how it comes about and the best way to deal with it. So when someone has hair loss, you need to have this particular table in your mind. It will help you reach the diagnosis, or at least gives you the best differential for that particular pattern of hair loss. So for example, if someone has diffuse or majority of the scalp has lost hair, we need to look at the things that can actually cause a diffuse hair loss on the scalp. And the common ones, we have that what we call the telogen, effluvium, and then we can also have anagen, effluvium. So, and this can be triggered by different particular causes, as we shall see in the subsequent videos. Then the less common causes of a diffuse hair loss would include things like lichen planopilaris, the diffuse type. It can include things like alopecia areata, the diffuse type, or even male pattern hair loss can sometimes be diffuse, but less commonly is it diffuse. Then if someone has a patterned form of hair loss, in this case, you'll now look at what is the pattern that you're seeing and the gender of the patient. So if it is widened part lines, for example, around the vertex here, where you see I'm drawing this line. So most likely, and your patient is female, that would be a female pattern hair loss, which we usually call the Christmas tree pattern. And the other alternative, or the other differential that can give you something similar is traction alopecia for women who plait hair that starts from the midline here going on the lateral side. So that can also give you that pattern of hair loss. Then when you say hair loss within either the frontal area here or around the temporal areas, like in this area where I'm drawing the line, so the common cause will be the male pattern hair loss, but even traction alopecia can give you something similar in the female patient. The less common causes can include things like frontal fibrosing alopecia, which I'll cover that later, and hyperandrogenism in women. That one we shall also cover it later. But if it is within the midline, or what we call the vertex in this area here, so it can still be the male pattern or even female pattern hair loss, depending on the patient that you're dealing with. And what you have to understand here is that the females can as well get the male pattern hair loss. So the other condition that can cause something similar is the centrofiducial cicatricial alopecia, the CCCA. So this is also commonly seen in women, but it is less commonly seen as one of the differentials. Then if someone has a posterolateral type of hair loss around here, going all the way behind the head, that will be most commonly alopecia areata, the type that we call omphiasis. Or if someone has the hair loss on the occiput here, a patient admitted, maybe they are in the supine position for so long, they can end up actually getting hair loss on the occiput here, which we call the pressure or post-operative alopecia. So that is the patterned form of alopecia, and the common diagnosis that you can reach when someone has that particular distribution of hair loss. So if someone has a circumscribed but non-scarring type, for example, someone has a well-demarcated hair loss patch on the scalp, or even on the beard area or the eyebrows, that the common cause that will be alopecia areata, which will give you the limited patch. But other things that can also cause hair loss can include things like the tinea corporis, the trichotillomania, that is a psychiatric disorder that whereby an individual starts to pull out their hair, maybe because of the stresses that they're going through, the depression, the anxiety, and they use it as a coping mechanism. So they'll end up having a particular uh, area that is affected that will have that circumscribed non-scarring type of alopecia or hair loss. As well as pressure, operative alopecia can also give you something similar. So in case someone has a well circumscribed and scarring type of alopecia, you can now classify those cases either it is inflammatory or non-inflammatory. So if it is inflammatory, you'll have to think about things like the central scar tissue, centrifugal alopecia. You can think about the lichen planopilaris. You can think about the fibrosing, frontofibrosing alopecia. You can think about the discoid lupus, erythematosus, folliculitis decalvans, dissecting folliculitis, even actinic keratosis, NICU, can also be thought about in this type. Then if it is non-inflammatory and it is scarring, you can think about the alopecia, which is like the end stage of lichen planopilaris. So we shall see this in the subsequent videos. But remember, in this case, this diagram actually is very, very key, and it is very good for you to memorize it and remember, because it will guide you when you're making a diagnosis of any type of alopecia. You have to first examine the scalp or the body, all the hair-covered parts, and see if the hair loss diffuse. That means covering almost everywhere on the body. That includes the eyebrows, the beard area, the chest, the genital area. If it is diffuse, then you think that A, the common causes can either be telogen effluvium or anagen effluvium. If it is the less common causes, they can be lichen planopilaris. But now in that case, you may need to look for other features of lichen planus, because lichen planopilaris can move with other syndromes or with other conditions, especially if you're looking at syndromes like the Graham-Little-Picardy syndrome, where you have lichen planopilaris, you have kepi-like lesions on the skin, as well as you having other maybe nail changes or maybe other skin lesions that are similar to the ones you see in lichen planus. So in that sense, you'll be able now to visualize and see that this is the diagnosis that I'm supposed to be thinking about in this pattern of hair loss. So if it is pattern, then you have to now examine more and see, is it male pattern or female pattern, or is it a male having or is it a female having a male pattern of hair loss? Then you look at the location of the hair loss, and then there you can think about things that can actually give you that particular manifestation. And if it is scarring and then you see evidence of scarring on the scalp, then you wonder, is it inflammatory or non-inflammatory? If it is inflammatory, then you think about things like lichen planopilaris, the discoid lupus erythematosus covering the scalp, the dissecting folliculitis of the scalp, folliculitis decalvans, and actinic keratosis. So these are the things that you should be running in your mind every time you are thinking about making a diagnosis of hair loss, whether it is scarring or non-scarring alopecia. So there are also particular bedside tests that you can usually do if you want to examine your patient where you're thinking maybe they have alopecia. And these are the simple tests that you can actually try to do and try and investigate and see and get a quick, like a preview of what is going on. The first one is what we call the gentle hair pull test. So you hold the hair of the scalp and then you try to pull it out. So, and in that case, that test can only be done if the patient has actually not bathed in the hair in the last 24 hours. If they have done that, then that means that you can't do that particular test because they have already removed the hair that are supposed to be lost in that particular time. So in case you do this test and then when you pull out, this is how the telogen hairs will look like. They'll have a bulb at the base of the hairs that you have pulled out. And this is usually expected because you expect that you should lose about 110 to maybe 50 hairs, depending on your age group, But as we grow that number can go up to 100 hairs per day, and that is actually normal. Then there's also what we call the tag test. In this case, you're trying to assess the fragility or the strength of the hair follicles and the hair shaft. So what you do is that you get the hair, for example, this is the hair. You try to hold at the base and then at the tip here. Then you try to pull and see if these hairs are easily breakable. So that will give you maybe there's a disorder of the hair shaft or there's any other feature that can be affecting your hair that you're dealing with. Then there's also what we call the plucking of the hair within a defined area. In this case, we can use like scissors or like how can I say like forceps. You can use a forceps which has like a rubber coating at the end. In this case, you target a particular area. Maybe someone is using hair in a given patch, so you target the area near that patch. Then you try to pull it out. So depending on what you get, you can now determine the ratio of the anagen hairs to the telogen hairs from the sample that you have obtained, and you have a standard of that ratio because the majority should be actually anagen hairs, as you can see here. This will now be normal. But if you see that a lot of the hairs that you pulled out are actually telogen hairs, then it means that you have lost that particular natural ratio between the anagen and the telogen. Maybe because there is a reduced duration and variability of the anagen phase of the hairs, and that is what is causing the excessive hair loss that the individual is having. Then we can also do what we call trichoscopy. Now in trichoscopy, you try to bring that magnifying handheld equipment and then you place it on the scalp and then you examine the hair and then see how much of this hair is looking normal, the size, the shape, the pattern, and the hair follicles, how are they appearing like the black dots, the yellow dots, the whitish dots. Then you note all those features that you see on trichoscopy. And different patterns of hair loss have different features on trichoscopy. All these you can do with the patient in your office. The other thing that you can usually do is the computerized trichometric analysis. In this case, it's the machine that helps you to analyze and assess the hairs that you are examining. This is not readily available, but at least the trichoscopy can be done even in resource limited settings. So as we look at this androgenic alopecia, so for androgenic alopecia, it has been given different names. Some people call it the male pattern or female pattern hair loss. Others call it the common balding. Others call it the hereditary balding or thinning of hair. So all these are the names that actually tell you what is going on. It's either male pattern or female pattern. It is inherited, and it is a common type of what? Balding that you will see everywhere at any individual wherever you're located. So depending on the literature that you review, you'll find that most of the people describe it as an androgen-dependent hereditary physical trait, which is characterized by conversion of scalp hairs from the terminal hairs that we usually see to thinned or what we call miniaturized vellus hairs in a specific pattern over a long period of time actually. So in this case, what we usually have as the terminal hairs, for example, as you can see on my beard, it is now made thin and it will be very thread-like, very tiny with a period of time. And then at the end of it all, it is completely lost in a particular pattern. So the prevalence is as high as 80% if you're looking at Caucasians by the age of 70 years. So it is very, very high. And then when you are looking at that is for men, when you look at women, for women it is as high as 50% by the age of 70 years. So meaning that the higher the age, the higher the percentage of patients that you will see presenting with this type of androgenic alopecia. The frequency and severity increases with age, and that is with this type of hair loss. So when you look at the pathogenesis and how it comes about, it has been thought that it has a genetic predisposition, and in this case, when you look at monozygotic twins, these are the twins that they look the same, everything the same. There's a very high concordance, meaning that almost if one has, even the other will actually get this pattern of hair loss with a very high penetrance, and that is what simply means that if you have that gene for hair loss, there are higher chances that you're going to actually manifest with androgenic type of hair loss. And then this genetic predisposition has been thought to be due to polygenic inheritance, and it is suspected that there are various genes that are associated with this type of hair loss. The first gene affects the androgen receptor, and also the other gene affects the estrogen receptor beta, and then as well as the aromatase enzyme that is usually supposed to convert for you testosterone into a very, very active androgen, the estradiol, that is also seen in the female pattern type of hair loss. And other genes that have been implicated include the histone acetylase, especially 4 and 9, that is also thought to play a role in the development of alopecia, as well as the Wnt gene that is usually thought to play a role in the development of the hair follicles via the Wnt signaling pathway. So these are the genetic loci that have been actually implicated to play a role in the development of either male pattern or female pattern androgenic hair loss or alopecia. So it is thought that androgens actually initiate and sustain the male pattern hair loss in genetically susceptible individuals. So meaning that after you having the genetic claim that you are at risk of getting this type of hair loss, now the androgen just come and give you a push to initiate the hair loss as well as maintain it throughout your life, such that you continuously lose hair as you grow. And by the time you reach 70, almost the entire head is bald. So this is where dermatologists now come in to try and reverse that, as well as try and make you look cosmetically better than if you were to lose all the hair. So what you have to understand as well is that when you're to look at these androgens, the most effective androgen is the dihydrotestosterone, the DHT. So that hormone is converted from testosterone using the 5-alpha reductase enzyme. And this enzyme is distributed differently in the different parts of the body. And there are different types. So usually type 1 of the 5-alpha reductase enzyme is purely located in the sebaceous glands as well as the liver. That's where we find it. And that means that in that area or in those cells, it will convert the testosterone into the dihydrotestosterone, which is the very active androgen. And then the type of this enzyme, the 5-alpha reductase, is commonly seen in the scalp, in the beard area, the chest hair follicles, the liver, the prostate, and type 3 is seen in the epidermis and the dermis, but the function of type 3 is not yet well understood. But what we know for sure right now is that this enzyme is very, very key in the development of androgenic alopecia. And it is seen that in patients who actually have or who don't have the type 2 5-alpha reductase, they never develop the androgenic hair loss. They never develop in their entire life. So it's someone who will have the graying, but they will still have their hairs throughout life because they don't have the type 2 5-alpha reductase enzyme that converts testosterone to dihydrotestosterone. So it has also been seen and proved in research that this DHT and the 5-alpha reductase is very high in the scalp for people who are affected by balding as compared to those that don't have balding. So meaning that these two factors play a very significant role or a central role in the development of alopecia. And we know for sure that the dihydrotestosterone contributes to the thinning of the hair follicles as well as the hair shafts as someone grows. Then other factors that are under investigation that may have a potential therapeutic role include the prostaglandin D2 and its receptor, which was found to actually inhibit hair growth in balding scalp, meaning that it may also have a role to play in the development of the male pattern or female pattern type of hair loss. So in the clinical picture, how will the patient present like, and how do you actually assess and grade these patients having this type of hair loss? So what you have to understand first is that this is a very slow progressive process of hair loss, and you need to classify the type of patient, either male or female, and the level of the hair loss depending on the different scales that we use. So for male pattern hair loss, someone will have this symmetric progressive with frontal parietal or frontal recession, and sometimes as well as the vertex thinning of hairs. And this can be assessed very well using the Hamilton-Norwood classification criteria that has seven levels. That is stage 1, stage 2, all the way through up to stage 7. So, and this classification, you can also use it if you are classifying a female who has male pattern type of hair loss. Then when it comes to females, females usually they'll get a diffuse central thinning. For them, usually the hair loss starts at the midline here, going all the way down. And in this case, we use another or other classification criteria. We can either use the Louding scale or the Sinclair scale to assess the level or the severity of the hair loss. And in this case, their type of hair loss, we usually call it a Christmas tree pattern type of hair loss, because it usually starts in the center here, going like this. So that's how usually the Christmas tree pattern is looked at. So looking at the Norwood scale, if you're assessing the male type of hair loss or the male type or male pattern androgen alopecia. So in stage 1, someone will have minimal or actually no hair loss. So usually when we're assessing, we look at this area that I'm pointing at here. So this is the temporal area, and this is the frontal area. We know we have the frontal bone here, the temporal bones here, and then the parietal bones around here. So the hair loss for males usually starts around the temporal areas here. Sorry, around the temporal areas here. And in stage 1, someone will actually have either little or no loss of hairs at the hairline here. So when you go to stage 2, they just have a slight recession of the hairline around the temple. So instead of having maybe a sharp corner here, they have a slight recession, meaning that the hairline has started to move backwards in this particular angle. Then in 3, they have a clear recession at the temples that you can actually clearly see even from a distance. And this is really the first stage of balding. Then later on, in stage 3, we now assess the vertex. Now the vertex or the crown, you start having thinning of hairs around the vertex here, where I'm touching currently, and that is in stage 3. Then 4, we usually have severe frontal recession, and then you have moderate hair loss at the crown here. Then in 5, then you have both the frontal and the vertex region starting to show significant thinning and hair loss, and having a bridge. So this hair loss continues this other side. Then the vertex is also growing, and then you have a bridge in between where you have actually normal hair. Then later on in 6, you have now this bridge becomes either very slight or minimal, or even disappears completely, creating a very large area of balding, which can affect all the way down, all the way here. Then in the severe cases, that is now stage 7, someone just has hair on around the periphery here, whereby this entire central area has actually lost hair. So this is what we've been trying to explain. So in stage 1, you just have either slight or no recession or hair loss at the temporal areas here. Then in 2, we now see marked hair recession, as you can see here at the temporal areas. Then in 3, you'll have this recession here, but then some people even start to lose hair around the vertex. Then in 4, you have now significant hair loss around the vertex here, as well as the recession around the temporal areas. Then in 5, you just have a very, very tiny bridge which connects these two areas of hair loss with just like a triangular patch of hair remaining at the frontal bone or the frontal area here. Then in 6, even this is lost. And then in 7, you just have a horseshoe appearance of hair remaining, but the rest is just bald area that usually is very, very shiny. And what some people resort to is to cut the remaining hair, then the head remains completely bald. So when we continue to the scale we use for female, the Sinclair scale, in this case, it is graded from 1 to 5. And in stage 1, someone has either no hair loss or even normal density of hair along the central part of the or along the vertex here, or along the crown here. So here the hair is still appearing normal. But then when you go to stage 2, someone has minimal widening. So this space here starts to widen out, and then in stage 3, you see now noticeable widening, and then you see that this particular area started to show what we call the Christmas tree pattern. You see this thinning here, one here going this side, and then here going the other side. Then in stage 4, you see advanced widening. Like now you see almost the entire central area is having thinned out hairs with a significant loss of the hair density, decrease in hair density and numbers, as well as the size, where almost every hair is becoming thinned out, what we call miniaturization. Then in 5, someone has severe hair loss with visible balding now. That is now the Sinclair scale for females. And then the loading scale, this is how it is, and it is actually similar. Just this one just puts it in type 1, type 2, and then also type 3. So in type 1, you see it's a little bit slow progress, and in type 2, a little bit wider, and then type 3, then to look like that with that well-marked hair loss region. So those are the skills that we use when you're assessing the level of hair loss if you are looking at either female pattern or male pattern hair loss. So when you do trichoscopy, this is actually what you visualize. When you look at the hair shaft, you'll see that you'll have both either the thick, which are through the normal hairs, and then the ones that are thinned out. As you can see here, this one is still very thick, but now this one is very, very thin. I think you can see the diameter of this hair follicle. And then you look at the density. In the center here, you see the hairs are actually countable. But as you move towards the periphery, the density of the hairs also increases. The other thing that we usually see is yellow dots, though in this particular video or picture it may not be very clear, but at the base here we usually see yellow dots that signify areas where the hair actually disappeared. Sometimes they can be here either yellow dots, black dots, and some of them represent opening of the sebaceous gland, where the opening of the hair follicle. And now in this case, if the hair is out, you just have now significance of the sebaceous gland. Then you usually see perifollicular discoloration. For example, if I may magnify for you here, in this picture, if you see maybe around this hair, maybe let me look for a good one, around this hair follicle, you see the color around the hair follicle has actually changed, even around this hair follicle, as well as around this particular hair follicle. So you're getting discoloration, and it will appear whitish. Then you have reduced hair density, which we've talked about already. You see at the center here, there are less hairs compared to what you see at the periphery. Then you usually see villus hairs that are not actually supposed to be on the scalp, and these are villus hairs, the ones that you see here, very, very tiny, and the miniaturized, very, very thin. And then you can as well see empty follicles without hair, and that is usually seen in severe forms of androgenic pattern of hair loss. So when you go to pathology of androgenic alopecia, in this case, usually on the scalp, we have what we call the follicular units. And in this case, we usually have 3 to 5 hairs, hair producing follicles, and that usually constitutes a unit. So you either have 5 of them aggregated together, and these are usually attached to one erector pili muscle. Then as you age, as you start losing this hair unit usually will now start to decrease in number from 3 to 5 to around 1 to 2 and to 0 completely. So they can go from 5 to 0. So every time you reach 0, that's when you see now the visible baldness, when you have lost almost all the hair. So when you take off a biopsy, you see that in this case, you'll have the normal number of follicles with no inflammation at all, but then you'll have an increased number and percentage of villus hairs versus the terminal hairs that is on your histology. And then you can see numerous fibrous or what we call streamers on histology with a slight increase in the telogen count. And if you look at the uninvolved scalp, if you take a sample here, maybe at the back of the scalp, you find that in that area, the hair there will appear totally normal. So this is how it will look like on histology. Now, in this case, you see here, this is a hair follicle unit, as well as this one here. But now you see the hair that is coming out here is what we call now the thinned hair. This is now how the villus hair will look like. So if you look at normal scalp on the normal cross section, that is maybe the horizontal axis, you'll find that this is how you're supposed to have the hairs arranged. Very many, almost uniform in size. All these are hairs. You get? But now as you bald, these follicular units start to decrease and then they become sparse. That is in androgenic type of hair loss. And this is how it will look like, as you see here, with all this redundant space where you don't have no more hairs. And then others have started to thin out, as you can see this one, as you can see this one at the end, as you can see this one as well, which is now villus in nature, instead of it being a terminal hair. So that is how it will look like on histology. Then, when you look at in terms of treatment, how do you approach these patients? One, the first and foremost, you need to assess whether this patient actually needs treatment. Because oftentimes in our setting and in our culture, balding is not looked at as a problem. It is something that even some people take to be prestigious. It is something that in some cultures indicates sign of wisdom, age, old age, and indicates that you are an elder. So if someone doesn't need treatment, there's no need to treat actually. It is in those particular individuals who are concerned cosmetically that they want to have their hair, they don't want to lose their hair, then you have to go through with them the different treatment options and the cost implication as well as the suspected adverse effects. So someone will say that maybe the best treatment will be hair transplant. You may be right, but in some patients, some people have a very, very difficult scalp that even with hair transplant, as you try to put in these hair follicles, they actually just pop out and they reject the hair transplant. Remember, someone will have paid their money and they expect a good result. So you have to take them through that. In some cases, even this can either do little or no change. So when we do in terms of treatment, even treatment is based on the gender that you're looking at and the age of the patient, because these drugs that we use in trying to reverse the hair loss have an effect on the fertility and on the sexual activity of the individual. For example, if we start with treatment in males, you can use maybe one of the following drugs. So you can either use the topical minoxidil, and you know that minoxidil was a drug that was initially used to treat high blood pressure, but it was realized that it was realized that people who used it actually ended up developing more hair. You understand? And that's why it ended up being now used in topical preparations to treat hair. So meaning that as we're giving these patients, you need to also assess them for other comorbidities that they have as well. You understand? Other drugs that we accidentally developed, like things like the sildenafil, which was also used to treat pressure, pulmonary hypertension, and the rest. And then they later on discovered that it had other functions that causing erections and the rest. So you need to understand that these drugs that you're giving, they can have an effect on somebody's sexuality and libido. So for minoxidil, if it is a male patient, you can give any percentage ranging from 2% solutions or 5% solutions to 5% forms, depending on the preparation that is available. And in this case, someone will apply on the affected area twice a day, but you have to advise them that this one, at first, it will come with mild scalp drying, irritation, and potential initially shading of the testosterone areas that later on now will come back. So someone can start using it, then they will tell you that the hair is even going more. You tell them that that is okay, but you have to add hair to the medicine, and then later on they will see the benefit. So the challenge with minoxidil is that once you start to use it, when you stop, the hair loss resumes from where it stopped. So it will just continue. So this is a drug that you tell someone that if you're opting to use it, this should be for actually a very, very long time. Then the other oral drug that you can use, you have drugs like finasteride. In this case, you can give 1 milligram daily, and this drug usually inhibits the type 2 5-alpha reductase enzyme that converts testosterone to dihydrotestosterone. That is a very active androgen that contributes to thinning of hairs and as well as the hair loss. So, but the challenge with this drug is that when you give it, it will give you libido loss. So someone will stop functioning. They don't have a sexual drive. It will reduce the ejaculation volume, and it can also give you erectile dysfunction in 2% of the patients. And there's also a potential risk, the post-finasteride syndrome, that comes when you withdraw your drug. So you have to explain to the patient as you're giving this finasteride that they may have little challenges in their sexual life. So if someone agrees, then you can give the medicine, then you keep monitoring. The option of hair transplant and scalp reduction is another alternative. For example, if someone just has maybe just a limited area of hair loss, you can just do scalp reduction. You pull the scalp, remove the area that is not affected, and then you repair, and that will be okay. So the other options. In this case, if you're managing two patients with hair loss, you can actually, currently, you can also do tattooing, permanent tattooing, where you now mimic hairs by just using ink, tattoo ink in the areas that have lost hair, and someone will appear like as if they have the hair that is growing, but in actual sense, it's just ink from the tattoos. Then, for if it was a woman that you're treating, the percentage of minoxidil, if you're using a solution, they only use 2%. They don't use the 5%. But if it is a foam, it's okay to use the 5%. So it is a little bit not that effective, but it is an option that you can use. And then other treatments, you can use the oral contraceptives. And this one helps us to suppress the androgens. You know that the androgens are very key in driving this process. And you can actually also use them in case the patient has hyperandrogenism, and this will help you to solve the problem of hair loss. So you can also use spironolactone. You know that spironolactone is one of the drugs that has androgenic effects, and usually either use it if you're treating male pattern, female pattern hair loss, but can as well use it in what? In PCOS, acne that comes with PCOS, you can end up using spironolactone. But in that case, if you're using spironolactone, you need to measure the blood pressure of the patient because it also has antihypertensive effects. So you have to keep monitoring the blood pressure of the patient. You have other newer drugs like the dutasteride. This is like finasteride, but more potent than finasteride. And it is not recommended if someone is still in the childbearing age, meaning that if someone is still giving birth and what, you cannot use this drug to treat their hair loss. You can also do hair transplant in case the hair loss is severe. Then you just pick hairs from the vertex here, from the occiput actually, and then you can replant them here, and then that can give someone a more time of her enjoying a youthful look. Then we have emerging therapies. Remember, we said prostaglandin D2 also has a role that it plays in the development of androgenic pattern hair loss. So there are other newer drugs that are being developed. There's a drug called cetipiprat, that is under study, that is an antagonist to this prostaglandin. So with later on, when it comes on market, we shall start also using it. But currently, remember, for females, 2% minoxidil. You can use your oral contraceptives or spironolactone, as well as finasteride. But you have to warn them that if they are still giving birth to children, they cannot use a finasteride or its co-partner, dutasteride. Then for males, you can either use minoxidil, or you can use transplant or finasteride as well. So that concludes our video, and I thank you very much. See you in the next one. Remember, we have, I think there will be around 5 to 6 videos about hair loss and the different types and how to approach each. In this case, we looked at the common type, what we call the common balding, which you can either treat or not treat. And in my opinion, unless when someone actually wants it treated, there's no need, because in society, in my culture, it is something that is looked at as sign of respect. Thank you very much. See you in the next video.